Welcome to Adapting Class. This is multiple patient prioritization case scenario for NCLEX case studies. These are strategies that require critical thinking. So stick around. Let me show you how to tackle this next generation NCLEX on patient prioritization, multiple patient. Let's go. This will be a case, and you see multiple patients. You have to figure out what to do with them. The first patient is a 4-year-old. What do you think? 4-year-old child in tripod position, dwelling, muffled voice, and what? Inspiration, stridor. Do you think this patient is okay? If you have to take care of this patient, what would you do? Multiple patient prioritization and case study. 5-month-old infant with saturation about 80% on room A, nasal flaring, grunting, lethargy, poor feeding. What do you think? Prioritization. See who you need to see first who is in trouble. A 3-year-old child fell from what? A skilled board, right? Headaches, irritability, confusion, vomiting ×2, and blood pressure of what? 160/80. What do you think is going on with this patient? 9-year-old child, history of sickle cell disease, now with what? Severe pain, 10 out of 10, saturation, 90%, room A, heart rate of 110, and then there's some pallor noted. A 7-year-old child with blood glucose of 300, potassium 5.6. There's a foot breath, Cushman respiration, respiratory rate of 30. A 2-year-old child with a seizure 2 minutes ago, temperature was 103.8. Now patient is post-ictal, arousable, saturation is 96%. What do you think? To master this NCLEX prioritization case study, multiple prioritization, the fundamentals of nursing to answer this question is what? Figure out what is wrong with them. Number one, what do you think is wrong with one? And then you can figure out who you need to see first. They're going to ask you questions about each of them. It requires some critical thinking. Stay put, don't worry. When they ask you about patient A, deal with patient A. That's all. So these are the patients, and figure out who we need to see first. This is the first question. The way I do prioritization is you have to be sharp. Look for the breathing issue, electrolyte, shock, sepsis, airway, and pain. And is this pain going to kill you? Then that's what you deal with. You can find more of this on Adapting Class. But you have 6 patients. Which order should you see them? I don't want you to say first. You got to know number 1. You got to know number 2, all the way to number 6. That requires some critical thinking. So let's apply some critical thinking and ask yourself, if you are being sharp, that means the patient is going to die. Number 1, there's buzzword there. Tripod position, dwelling, muffled voice, and inspiration stridor. This is epiglottitis. I think we got to see him first. A 3-year-old child fell from skateboard on equal people, confused, vomiting. That's neurological problem. But we have a patient who is a 5-month-old, an infant, is saturation 79, nasal flaring, grunting, lethargy, and poor feeding. I think that patient is more serious. We don't have time for him. Respiratory problem. The neurological patient, we should be able to take care of it. That will be the third patient we have to see. We have time. We may have to get CT. We have to elevate the head and all the thing. But 5 is also drowning. Now, you have a 9-year-old child, sickle cell disease, severe pain, right? And you have a 7-year-old with what looked like a DKA. And then a 2-year-old who just had a seizure. So post-seizure disorder. Post-seizure disorder, DKA, and what? Sickle cell crisis. What do you think? We should go ahead and deal with the DKA because of the hemodynamic stability, right? You have a potassium that is high. You have dehydration. It's more serious than sickle cell patient. And of course, don't be confused about a seizure patient. You already had a seizure. What you need to do is just now monitoring. This seizure was a febrile seizure. So now you got to monitor the patient and figure out what is going to happen. 6, prioritization. What was your score? I know you got it. But be able, when you're doing case questions now, and you see prioritization, I know they will ask you which one you should see first. But at the back of your mind, try to arrange them in order that you should see them, because that's what they'll be asking now in the next generation faction. And so you should be comfortable. Don't panic. When you see questions like that, don't panic. Just sit back, look at it. You see who is more serious. You don't have time, and you can figure out who you need to see and arrange them in order. Now, we're going to match the priority. What does each patient need? This is the order that they're asking these days now. So this is the next generation case study, trying to trick you, trying to see if you have stamina. They want to know if you can handle this kind of clinical situation, because these are real life. You know, you'll be giving multiple patients and you have to figure out how to take care of them. So this is the orders, right? You have client A as epiglottitis, client B as sickle cell crisis, C had an end injury, D is a DKA, and E is an RSV patient, and F is a febrile. What do they need? Priority intervention. Who do you think need an antipyretic and seizure precaution? Who need oxygen, IV fluid, and opiates? Who need IV fluid, insulin, and cardiac monitoring? Who need high flow oxygen, suctioning PRN? Who we need to prepare to intubate, no examination in the oropharynx, and keep the patient calm? Who we need to elevate the head of the bed and get a CT scan and what? Monitor. If you know the answer, you can put down in the comment. And I know you know it, so put it in the comments. Let's discuss it. So what kind of intervention is appropriate for each of them? Epiglottitis, you know, of course, we got to prepare to intubate that patient. We shouldn't examine the throat, and we should keep the patient calm because airway emergency. Sickle cell patient, hydration, provide oxygen and improve perfusion, and then pain management. Head injury patient, you got to elevate the head of the bed, get a CT scan, and try to decrease the edema by giving the patient mannitol. A DKA patient is dehydrated, so we're going to give them fluid. And then we give them insulin and cardiac monitoring due to what? The potassium. And of course, RSV infection, bronchiolitis is also mostly respiratory. So we got to give patient oxygen, suction them as needed, and then continue to monitor them so that they don't get sick. And of course, seizure precaution is a febrile seizure. So we control the temperature and then provide seizure precaution. These are the ways they act in next generation and cluster stage. So you have to be comfortable. I just want to make a video so that you can be comfortable. If you're taking the test recently or you're about to prepare, you don't get panic. Don't panic. Just stick around and say, throw it at me. I can handle it. It's the same thing. They're just trying to figure a way to confuse people. But this is a table. It's nothing. It's just like select or apply or which one you should match. It's a matching game. Now, there's a clinical priorities, right? For each of them. It's different from intervention. There's specific generalized priority. What is the priority? And it can be classified into this stage, right? So first patient is epiglottitis. We know we have a sickle cell patient. We have a head injury patient. And we have a DKA. We have RSV infection. And we have febrile seizure. There's some priorities we have to be comfortable with. Number one priority is what? Provide patient and family education. Of all these 6 patients, who do you think need family, what? Not intervention, not the initial intervention, but overall clinical priorities. Who do we have to provide patient family education? Is he a epiglottitis patient? Is he sickle cell? Is he head injury? Is he DKA? RSV infection, and febrile seizure? The right answer is a febrile seizure. They are the one you have to educate the parents about how to take care of it when the temperature goes up, how to monitor it. Somebody will say epiglottitis, but that's not number one of the clinical priorities, right? Our clinical priorities is prevent neurological decline. Our clinical priorities for a patient with to prevent neurological decline is the patient with a head injury. So that's number 3. Who we need to support circulation and perfusion. If somebody who is dehydrated, who is dehydrated over here? It's a DKA patient, in addition to sickle cell. But the sickle cell patient is more serious. So I will provide circulatory support, number 1, to sickle cell patient. The DKA patient is mostly electrolyte issue to fixed, right? So that's where we will deal with. And then to stabilize the airway, there's 2 people, RSV infection and epiglottitis. Those are the 2 that will need airway stabilization. But initiate specific condition therapy, I think it can be all of them. So that one, we're not going to focus on it. And to manage electrolytes and metabolic imbalance, we're talking about DKA. So if you see a question like that, that's what it means. Like the clinical priorities, like what is your priority? Like the head injury, our priority is to what? Prevent neurological decline. Diabetes patient, we want to manage the what? Metabolic issue that is going on and the electrolyte imbalance due to the sodium, potassium, and then and the associated metabolic condition. Sickle cell, is a dehydration patient, and then they become hypotensive. We have pain, so support the circulatory perfusion. And then epiglottitis and the RSV, we are going to stabilize the airway. So don't panic. This is the way it should be done. And then so when you see questions like that, then you can figure out. Now, match with the most appropriate short-term outcome. When you take a patient and you're taking care of them, when you're on the ward, there's always a short-term outcome. What do I have to achieve in a very short time to improve the patient's symptoms? So this is it. Epiglottitis. What do you think we should achieve in terms of our short-term outcome? Sickle cell crisis, headache, head injury, DKA, RSV, and febrile seizure. What do you think? Of course, if you have epiglottitis, airway is our number 1. So we want to ensure patient has airway, right? Saturation improving, we're preventing stridor. What do you think about the sickle cell patient? The most important thing is what? They have pain. They have perfusion problem. They have other issues. So that's what we're going to do. Pain relief, saturation 95, and warm skin. So this kind of next generation is a little bit intimidating, but if you step back, you can see that you can figure it out. I know you watch Adapting, so this will be for you. You'll be able to handle it. Head injury patient, of course, if you look at the other choices, I want to decrease ICP. So ICP should be normal. They shouldn't be vomiting anymore. And a DKA, as usual, the definition of DKA is your endpoint. DKA is diabetic ketoacidosis. Therefore, my short-term outcome is to prevent diabetes. That means what? Sugar should be normal. Ketoacidosis, there should be no ketones. And then acidosis, there should be no acidosis. So that's the one. And the RSV infection is also airway issue. Saturation higher, reduce the work of breathing. And the febrile illness, there is no fever and seizure-free. So these are the classic 4 questions you may see. There's 2 more, but I changed it a little bit. They may give you when it comes to this kind of multiple patient prioritization. So this is the fundamentals of how to answer multiple patient prioritization. It's the same kind of case study you've been seeing in the Q banks, but this is a different way. This is the way they acting recently, and people are freaking out. Don't. This is it. Just sit back and look at it and say, okay, I can handle it. Now, if they give you 1 patient, they say focus on 1 patient, focus on that patient. So I'm giving you a question. I say, see, what should the nurse expect? Say, look, it's a head injury. No matter what table they give me, head injury. What should I see in the plan of care? That's all. Should the head injury patient get what? 0.45% normal saline? Ask yourself. Should we expect a prescription for enoxaparin for head injury patient? Should we prepare to intubate that patient? Should we suction the client every hour if intubated? What do you think? You can put your comment in the comment section. Should we monitor temperature for patient with a head injury? And should we calculate the cerebral perfusion pressure? This is brain injury. We expect the patient to having signs and symptoms of ICP. In the management of ICP, we want to decrease edema of the brain, giving them 0.45%. This is fluid and electrolyte. I've done a bunch of series on fluid and electrolyte. You should watch it. This will help you realize that head injury patients should never get hypotonic solution. Therefore, we should not include. Head injury patient who is bleeding should get sequential compression device, non-enoxaparin. Head injury patient will be prepared to intubate them because they may lose their airway. Do you want to suction them every hour? No, that is going to increase their ICP. Of course, you got to monitor their temperature because high temperature metabolic will improve, worsen their ICP. What is cerebral perfusion? CPP is your MAP, mean arterial blood pressure, and your ICP. Therefore, we got to ensure setting CPP. That means cerebral perfusion pressure. That's how much blood is actually going to the brain. If your ICP increases and your MAP remain the same, your CPP go down. So the strategy is to make sure our MAP is mean arterial pressure is high enough so that even though our ICP is increasing, our CPP is also fine. So if your ICP increase, it decreases your cerebral perfusion pressure, and then the brain cells will die. We want to improve cerebral perfusion pressure. So the nurse should be able to calculate cerebral perfusion pressure by titrating the mean arterial pressure. And so this is a critical thinking question. Like you got to improve your MAP in order to overcome the increase in ICP so that your CPP may be enough to provide perfusion to your brain. This is critical thinking. And that statement I make, if you write it down, you see that when you see questions related to that, you can understand why we got to maintain your blood pressure normal when you have head injury in order to ensure you have your cerebral perfusion is normal. So that's what we do. So this is what it look like. It can change. I can put so many information parameters based on what I expect you to know for when the head injury patient, what do you anticipate? I can put antiemetic. Yes, you don't want them to be vomiting, right? I can put the head in the midline. I don't want you to turn the head back and forth if they're intubated, right? You suction them as needed. This is next generation NCLEX ICP management. Now, I pick another patient, patient E, a patient who is what? Less than 6 months old, a very young patient. So what do you think? RSV, bronchiolitis, what are the things you need to do? This is infectious control. Do you initiate contact or droplet precaution? Do you administer antibiotic? Should you keep the door at all times closed? Should you administer oxygen for this patient? Suction them as needed? Administer ibuprofen for fever? Wear N95 masks for routine care? What do you think? RSV is mostly contact precaution and a little bit of droplet. So it depends on the institution. For the NCLEX, I would say pick both, contact precaution and droplet precaution. It's a viral infection. Why do you need antibiotic? Whether contact or droplet, the door does not need to be closed at all time. The word is may be closed. The only infectious control disease process that you need the door to be closed at all time is airborne. So we don't do that. Of course, the kid needs oxygen, and you suction them as needed. Then what do you think? Administer ibuprofen for fever. No, the kid is less than 6 months. If you have to be more than 6 months to get ibuprofen. And should the nurse wear N95 masks for routine care? I just said it's contact and droplet, so negative. So this is respiratory syncytial virus infection, RSV infection, and this is the management the nurse should expect to be included in a plan of care. Finally, we got to send them home. Read to the following statement are correct discharge instruction. For each of them, tell me whether it's correct. Like I said, this is the way they asking the next generation NCLEX. So we're doing NCLEX practice questions, NCLEX review questions using next generation strategy in multiple patient prioritization. So there's multiple patients and we're picking one of them and then we talk about them. We have already arranged them in the order we should see them. Therefore, epiglottitis. Is this teaching okay? Well, you get epiglottitis because you were not vaccinated. 2468, right? Therefore, before you pass 1 year old, you should have get everything. The kid is not vaccinated. That's why you got it. So ensure that child receive vaccination. That's the correct teaching. How about febrile illness? Who know it? If you know it, you can put it in the comments. But should you anticipate a new prescription to prevent seizures if you get febrile illness? What do you think is the management? You may see this in a standalone question. If they give you a case where patient had seizures due to fever, there's nothing to do. Prevent fever later on, but you don't need medication for seizures. RSV, of course, eye usage, suction them, and hygiene so that you don't get infection. That's good. DKA, well, you get DKA because you think if you're sick, you shouldn't take your medication. Therefore, never skip insulin during illness and monitor your ketones. You can taste your urine, but all of this is acceptable teaching. LDG patient, vomiting may continue for a couple of days. Do you think this should be a good teaching for a patient who had the NDG? Of course not. A sign of vomiting is a sign of ICP. That means you're having something going on in your brain. Therefore, bad teaching. And finally, Sickle cell. Take the prescribed hydroxyurea during attack. This is a content-based hematology. A patient who has sickle cell should not take hydroxyurea when they have acute attack. Hydroxyurea is a maintenance medication. It's not for acute attack. These are adult class, 6 patient prioritization, NCLEX practice question, next generation NCLEX, teaching you how to handle them. If you like this video, you can share with your friends, and you can join our membership. We have membership on Adapt NCLEX where we have videos you can get access to, and that will help you be very high yield, will help you pass your nursing school and the NCLEX. And if you want more, you can join, you can subscribe to my on-demand. I have a bunch of QBank associated with it. Thank you for watching and good luck in your exams. Take care.